So we move on to our next plenary of the day now, which is what difference is research making to healthcare delivery and patient care. So we've got some guests coming to the stage, so if they could make their way up. Dr. Dean Harris, Consultant Colorectal Surgeon, Deputy R&D Director at Swansea Bay University Health Board. Welcome to the stage. Dr. Nathan Bray, Senior Lecturer at Bangor University. And Peter Hooper, who is a public contributor who's going to share his story with us in the research world as well. So do come and take your seats. And the microphones hopefully are on and on the table there, so I don't forget again to make sure that you pick them up and share the microphones. Thank you very much indeed. So in this plenary session, we're bringing together thought leaders from clinical practice, academia, NHS senior leadership, and the public with Peter to explore the difference research makes to healthcare service delivery and to patient care. Reflecting on that decade of progress, the session will examine how research has shaped healthcare, improved service delivery, and impacted on the care that patients have received. So what difference is research making to healthcare delivery and patient care? So we'll be discussing different research, how it has made a difference to patient care over the last 10 years. So if I could first ask each of you to introduce yourselves to the audience. Shall we start with Dr. Harris, please? Oh, you have the microphone. Excellent.
Hi. Hi, everyone. My name's Dean Harris. I'm a consultant colorectal surgeon in Swansea Bay University Health Board. I'm also Deputy R&D Director, so work closely with Steve Bain and the Swansea Bay R&D team. I'm also a co-founder of a company called CanSense, which is a spin-out company from Swansea University developing a bowel cancer blood test. Thank you.
Thank you very much. Shall we do all the introductions and then we'll do a round of applause? There we go.
Thank you. Hi, I'm Dr. Nathan Bray from Bangor University. I'm a senior lecturer, health economist by background. Particular interest in disability and how we measure the cost effectiveness of assistive technology, in particular wheelchairs for very young children. I started my career in research actually with NISCA CRC in North Wales, then did a PhD with NISCA, and then have had a couple of projects funded through HCRW as well. So very excited to be here and to share my experiences over the last decade and slightly longer in my case as well.
Nathan, thank you very much. And Peter.
Hi, I'm Peter Hooper. I'm here because I'm a member of the public, according to the programme. I'm also a patient with lived experience of stroke and atrial fibrillation. In a former life, about 3 lives ago, I was in research support at University College London and University of Southampton, where I was Director of Research Support and Deputy Director of the Centre for Enterprise and Innovation. So this room really feels like my happy place from the good old days. I'd just like to add that working in research support is a fantastic career because you get to work alongside people like Ian, Michael Marmot at UCL, and Wendy Hall, for example, at Southampton. All the others so far have got knighthoods, most of them all deserve sainthoods, and I'm pretty sure that Ian is on that trajectory as well. So that's me.
Thank you very much. Let's give them a warm welcome to the stage. Thank you. So reflecting on the last 10 years, looking back over the last decade, where have we seen research, do you think, make the biggest difference to how healthcare is delivered in Wales? Do you want to take that first, Dean? Or Nathan? Nathan, you go. Either or. Who wants to go first?
Thanks. I thought long and hard about this question, and I think the easy answer that crosses all sort of specialties is personalisation of care. I think that's come on in leaps and bounds in the last 10 years. So I'm a colorectal surgeon. I sit in these MDTs that Ian was talking about, drinking coffee. It's perhaps the only time of the week we all actually meet our colleagues nowadays. We're all spread so far and wide. But the thing that's really revolutionised how we treat colorectal cancer, for example, is all that molecular information we get from sequencing these cancers. So if you think back 10 years ago, if you had you know, if you had a liver metastasis from your cancer, you get the bog standard chemotherapy, you have a 30% chance of survival. Pretty dismal, really. But nowadays, we sequence the cancer. We've got precise treatments for these metastases. Wales was also one of the first countries that routinely did genetic screening on every patient that was diagnosed with a bowel cancer. We started this from Prof. Ian Frayling's work on the health economics of that approach around 10 years ago. And it was great at the time, but no one really could see how it would help, apart from sort of reflex testing of family members. But if we look fast forward 10 years to where we are now, based on somebody's bowel cancer having a specific genetic mutation means that we can treat them with immunotherapy. And we're seeing patients now where surgery just doesn't need to be done anymore for a rectal cancer. You know, the disease vanishes with therapy, which is just astounding, really. And that would never have come along without that sequential journey of, you know, one research idea and publication triggering the next one, triggering the next one. And now we were one of the first countries in the world to use a drug called dostarlimab to treat rectal cancer, which is just a phenomenal story, I think.
Better for the patient and better for the system as a whole not to have to rely on that surgery.
Going to put me out of work, yeah.
Nathan.
Thank you. I think there's so much, well, we've seen today how much amazing research there is and how much impact it has. When we think about the research that we do in Wales, we punch above our weight, both in terms of the quantity and the quality of research that we do. We look at metrics like citation impact, and we see that we are doing much greater than the global average and also better than the UK average as well. So although we are reasonably small as a community, we're also incredibly, we work hard and we're impactful as well. So I could single out lots of different areas, and I think it's tough to do that, but some of the things that come to my mind is around diagnosis. So we've seen in dementia, so the work of for instance, Jill Windle and the Dementia Services Development Centre in North Wales, their work around diagnosis and supporting people through that process, and then also the support for carers as well, and resilience is really important. We also see it in cancer diagnosis in primary care through the work of the North Wales Centre for Primary Care Research and Prime Wales as well, around the diagnosis of cancer in primary care and detecting earlier so that you can then refer earlier as well. From a health economist perspective, obviously there are benefits to be able to detect illnesses sooner, because you can start treatment sooner and avoid the risks of complications that might come along with later detection. I also think that Wales's response to the COVID-19 pandemic was really interesting. We funded over 100 research studies, but not only that, we were able to operationalize our research community and to leverage our skills to create impact on policy and practice through, for instance, the Wales COVID-19 Evidence Centre was able to influence practice and policy through evidence reviews in a rapid way, which I think is fantastic that we were able to respond so quickly to such an unprecedented event. And then that's carried on with the Health and Care Research Wales Evidence Centre into other areas. And I think it's really key that we do primary research, but we're also able to convert our research into impact through evidence reviews and synthesis and so on. And then I think another thing is we often focus on treatment and cure, but actually it's important that we think about end of life as well. So the work that's been done in Wales around palliative care, end of life treatment, working with hospices like T Gobaith and Hope House, I think is really important to ensure that we give people the correct care at the end of life and to allow them to die with dignity as well. So lots of areas, and I think we've got a lot to be proud of in terms of the research impact and that translation into healthcare delivery.
Thank you. It gives a lot of hope that it's impacted in so many different areas, and they're quite diverse as well. And Peter, I'm glad to hear this is your happy place as well that you return to. What's your take on the last 10 years?
My happy place is out there. I've been giving this a lot of thought, and as a patient, as a member of the public, we see the improved treatments and the wonderful new drugs and all sorts of improvements. What we tend not to see is the dotted line back from that to all the wonderful research that's going on. And I think that's possibly why the public find it a bit harder to understand the importance of research. They see all these massive announcements in the media about the new cure for cancer, as if cancer's a single thing, and then nothing for 5 or 10 years. But actually, there's fantastic research going on all the time, and it's leading to all these wonderful new treatments and discoveries. I don't know how you do it, and this is bang in Health and Care Research Wales' remit, I think, is to make that dotted line a bit stronger. There are plenty of really good impact stories, and we know those, but I think you could do it across such a wide range of treatments.
I think you're right, because we are guilty of that in the media. We're looking for that final headline, that big headline, aren't we, of the success story. But as you say, these research projects take years and years and years in the background, and that's what we don't hear about so much. So it's a difficult job to be in comms for the research departments, isn't it? Nathan, how has research contributed to improving healthcare outcomes or reducing health inequalities in recent years?
Yeah, I think there's been a lot of work in that area. We know, and it's been spoken about quite a lot today, the issues in Wales around deprivation, around health inequalities, unemployment. We have higher disability levels than in other parts of the UK as well. So there are pressing challenges around ensuring that we're able to provide, to improve on health inequalities in Wales. And it relates to the inverse care law, and that people who are often in most need are the least able to access support services. So I think there's certainly more that we can do, but there are areas in which there has been some fantastic research in terms of health inequalities. So for example, the development of the Family Resilience Assessment instrument by University of South Wales, I think is a really important element of research that was done to combat health inequalities, which will support a range of different individuals to ensure that families who are most in need are able to be supported, particularly in terms of health visitors and so on. I think also the work of Public Health Wales, their work on digital exclusion, I think is really important, and that's something that going forward is going to be really important, is that everybody is able to move forwards with the future of healthcare, even if that means it's in a digital space. We're still able for everybody to kind of keep up with that. Social prescribing, I think, is really important. We're seeing more of that, and it's bringing the prevention agenda into communities, which is something I think we need to focus more on. From a strategic point of view, Welsh Government funded the Intensive Learning Academy programmes across Wales. I lead one in Bangor, focused on health equity. We have 3 others: digital health, innovation, and the value-based healthcare. And what's really great about those is that they are mainly focused on training and postgraduate education, but within each of those academies is an element of research. So we have that sort of pathway from generating evidence to communicating that evidence to our future health and social care leaders. So I think that's something that we really need to focus on, is that knowledge translation. And then also in the future we have the health determinants research collaborations, which will be with working NIHR funded and working with local authorities to do more research on inequalities within the local area. And I think that's something we need to do more, is to think locally about what individual communities need for tackling their particular issues, rather than thinking nationally. And although there's an element of needing to do both, I think we could do more to think locally and community-based.
I think that social prescribing is another good example that I think we reported on that in the news in the beginning, but then it's following up, isn't it, to see what's happening with people and what effects that's having on inequalities and helping people and their outcomes. Thank you very much, Nathan. Dean, I want to talk a little bit about how research has improved the way cancer is diagnosed. We've actually did a programme recently at ITV Wales on Wales This Week with Craig Maxwell, who's been raising a lot of money to change the way that cancer is diagnosed with quick DNA. So that's sort of been on my horizon, but I'm sure there's many other things that are going on as well.
That's right. It is a really, really exciting time, and cancer is becoming so much more prevalent, and we, really don't understand why there's been this shift almost towards earlier age of onset of cancer. So, I'm regularly seeing people in their 40s with really advanced bowel cancers, and the breast colleagues, ovarian cancer colleagues, all seeing similar people in below screening age, very few symptoms, and also that lack of GP awareness that cancer isn't just an old person's disease anymore. And there's also been, so that's part of the issue why we really do need better cancer diagnostics, but also I think the Cancer Research UK campaigns about making people more aware of cancer symptoms. That work's been fantastic, but it's led to an absolute flood of people coming through with symptoms. They're doing the right thing, they're being referred into the pathways, but the systems are under such strain. We've only got so much finite colonoscopy, CT scanning capacity to deal with all of this.
So many people as well,
Yeah, that's right. So, we do need better tools to be able to sort of triage and find out from people with symptoms who really has got cancer and who can be more safely reassured at a much earlier step and point in time. So, my own research around the CanSense blood test hopefully it's going to make a big difference in that. We're able to put it in the hands of the GPs, hopefully from next year, where GPs will be able to do this simple blood test, reassure patients right from the outset, and not necessarily refer them in on a cancer pathway. We've modelled that we would be able to reduce the number of unnecessary colonoscopies by about 2/3. And when you think that these cost £1,000 per test, and they are horrid, the bowel preparation and the toilet story that we heard earlier, people don't need to go through that unless they're really going to benefit from having it done. We could save £65 million for the NHS a year in unnecessary colonoscopy costs alone, never mind the costs of late-stage cancer treatment, which can be, £30,000-40,000 as opposed to, £1,000 to remove a pre-malignant condition. So, there are other blood tests coming through. You hear stories about like the Grail test, looking at DNA fragments in the blood. And Wales were one of the highest recruiting sites in the Simplify study just after the pandemic. We recruited 1,300 patients in just a few months. That study didn't quite have the outcomes in terms of the test performance, but it does show the public's appetite for having a blood test for cancer diagnosis, with 98% people preferring that to traditional ways of invasive diagnosis. So,
what's the timescale on that?
It's really exciting. Yeah, there's different tests at different stages of development. Our CanSense test is looking to get its UKCA mark this year, and we're hoping to put it in the hands of the NHS right from next year. But this has been a 14-year journey right from our first idea over a coffee table in Swansea University in 2011 to it becoming ready for public use now. So, that's a bit of a plea that you talk about the timeline of getting research ideas into making headlines. 14 years is way too long. We saw the promise for this many, many years ago, but, it's taken too long really to get to where it is now.
Fingers crossed it won't be too long now. And Peter, I know you speak from a patient's perspective, but also from a research perspective. But how has research made a difference to the care, support and outcomes people you receive? And from your own experience as well as a stroke survivor, what's that experience?
I was going to cover this actually from my experience of the past 4 years in Wales, and the work I'm doing, for example, with Health and Care Research Wales on their grant review bodies, and looking at projects I know that are coming through, where I've been lucky enough to be on their PPIE bodies. And there's a couple I'd specifically like to mention where the research is active, but I can see a really potentially quick and very positive outcome into the patient experience. So the first one is fundamentally, I think Wales is in a fantastic position to have the SAIL database, because I see and hear so much about the studies that are being generated on the back of that. So that's a huge thing to celebrate in Wales. So both the studies I've got in mind are from Cardiff, one from Cardiff Met and one from Cardiff University. The first one is Cardiff Met, and it's a study called Quest. I'm just scanning the audience to see if I see Jess, in case I get into trouble.
She's smiling, I think, so it seems to be okay.
It's a study looking at TIAs, so transient ischemic attacks. My stroke, I think, came completely out of the blue, and I don't think I had any warning signs, but I'm not sure. There were one or two odd events about a year before my stroke. So I've got a real interest in TIA, and it's a really important thing to be picked up by GPs and A&E. But the study that Jess is doing is looking in two arms at TIA, one retrospectively from the SAIL database if they have had a TIA, and then following that, and the other prospectively. Really, Jess. Fundamentally, it's looking at, do TIs get identified correctly, and do they lead on to a stroke? And the fact that they're looking at TIs that have been diagnosed and then following that forward, but also looking at TIs retrospectively and did they lead to a stroke? It's showing that TIs that were correctly identified as a TIA did go on in many cases to a stroke, but TIAs that weren't then diagnosed as a proper TIA, the risk of a stroke after the not a TIA is actually quite significant. So that raises all sorts of interesting questions about how do you define a TIA and how you monitor it and follow up. So that's massive. That's a real potential lifesaver and could transform treatment pathways in the future. And the second study, it's got a really complicated name, which has lots of initials that I can never remember, but it's out of Cardiff University, and it's basically looking at secondary stroke, the treatment, reducing the risk of a secondary stroke. All of us, and I know quite a few of us that have had a major primary stroke, you've always got this doubt or fear at the back of your mind that the next one's coming. And there's all sorts of treatments and protocols that you ought to be on and followed up by primary care. And the study at Cardiff University is just looking through SAIL to evaluate what follow-up a patient's getting after a stroke and whether that is adequate and protecting them properly. So, and that raises another important issue about, research. It's a broad brush. You've got peer research, you've got applied research, you've got evaluation studies. You then stray into sort of audit and areas like that. And it's really important, if you have a treatment, to make sure it's being properly implemented and undertaken. So both those instances, I think, are really good examples of where, in Wales, SAIL is having a real impact in terms of the data that's there, and really interesting studies right across the piece are happening that could actually have a pretty quick impact on patient care.
Good to know that, looking at that before the stroke and also after your stroke, preparing for another one is absolutely important on both levels, isn't it? Thank you. And I suppose, everyone's talked about funding a lot and the costs of all of these things, but Nathan, it delivers on the other end in the value, doesn't it? It to the system, to the NHS in the end, and for everybody in the end.
Yeah, I think absolutely thinking about value and the health economics is really important. We have a good community of health economists across Wales through a number of different organisations and centres, like the Centre for Health Economics and Medicines Evaluation in North Wales, the Swansea Centre for Health Economics, CEDA in Cardiff, Health Technology Wales, and then also the infrastructure grants with Health and Care Economics Cymru. So there's a really good basis for evaluating health economics and value, and then communicating that to commissioners and the health service to ensure that we are using the limited and finite resources that we have available to us in the most efficient way possible. I think that the challenge for health economists is that often we're seen as like penny pinchers, or people who are just out to count money and to save money. The reality is that most health economics research is just as interested in outcomes and attributing value to outcomes as we are to the money of it. And there's far more than economic evaluation to the work of a health economist through social return on investment, program budgeting, marginal analysis, qualitative health economics as well, using tools like discrete choice experiments will help us understand patient preferences for the way that we organise services, so that we can ensure that we have good adherence and compliance with treatment plans and so on. I think it's a testament to the work of people like Rhiannon Tudor-Edwards, Deb Fitzsimmons, Doug Hughes, and aspiring and upcoming leaders like Emily Holmes and Carol Davis for the work that they've done to not only do the core elements of health economics, but then to think more broadly about like public health economics and bringing health economics into the social care space as well. And then also the methodological work, and we're very lucky to have been one of the partners was based in Wales, across Wales, to develop the new scoring system for the EQ5D, which is the outcome measure that NICE use for developing their quality adjusted life years for the health technology appraisals. So having Wales represented in that is really important, so that the societal values that those outcomes reflect are reflective of the whole of the UK, not just of England or England and Scotland, or however they have originally in the past developed those scoring systems. So I think there's also a lot of work. It's not just about like looking at trials and economic evaluations, but also we can look at the value of screening systems, of prevention as well. Look at the social value to communities and to the nation as a whole. So there's a lot that health economists, I think, can kind of bring to the table. And I would really like to see health economics embedded in some capacity in all research that we do in health and social care, because I think that's how we learn how to use the finite resources we have in the most efficient way possible, and then also ensure that we can bring in considerations of inequalities and health equity as part of that process as well, through things like distributional cost effectiveness analysis and social return on investment. Thank
you. The patient view, the clinical view, and the economic view as well. So with all that in mind, Peter, if I can come to you first, where are the gaps, would you say, in research that you feel need to be addressed to improve care for patients? Where do you start? Are you going to say?
No pressure. No, I was really hoping I was going to be last for this one. This is from a very personal perspective, because I'm fortunate enough to be able to engage in PPIE work and grant review and all these other good things, and work with the British Heart Foundation and the Stroke Association in Wales on their national advisory bodies. The bit where I don't get a huge sense that there's a lot of research or evaluation going on, and that's purely my perception. It might be rammed out there in research and evaluation, but it's in primary care. So much I hear about is acute care, and that was certainly my experience when I was working in research support in medical schools. there's a lot around the acute end, and I think particularly now, I cannot think how you could easily carve out some research time in a busy GP practice. And I think in many respects it's more important to get it in there, in picking stuff up early and in prevention, to have a stronger pathway for research. That is very much a personal perspective, and I'm very happy to be contradicted that all is rosy out there, but that's a big gap that I sense.
Thank you. That's really interesting, and we'll have some time to hear from the audience who might contribute to that as well afterwards. Thank you. Nathan?
I think echoing what Peter said, I think there's certainly areas where we could do more research, and we do have centres for primary care, but I don't think that they are they don't get the same level of funding as, for instance, acute cancer treatment or other areas. I think for me, it actually links to the work of Peter in having more PPIE built into every single grant. So I was fortunate recently to have a grant funded through Health and Care Research Wales, and as part of that we have a co-applicant who's a public advisor with lived experience, and having that individual, Jackie Hughes, to give her a shout out, has been really powerful in terms of making sure that we are able to be inclusive and accessible, and because it's research about disability, to ensure that we have the patient perspective built into that means that we can be representative of the individuals that we're trying to support. And I think it comes back to the old saying of nothing for us without us. So I think that ensuring you have that public voice guiding a project all the way through and not in a tokenistic way is really important. So that for me, that would be a key area where I think we could, and I think that Health and Care Research Wales has been fantastic in promoting that. So I think it's a case of just keep rolling with it, keep building on that. It's something that's grown a lot over the last few years, and I'd like to see more of that, both in terms of delivery of research and also the development of ideas for research as well. I think also just making sure that we are representative of marginalised groups. We know that traditionally a lot of research is it doesn't cater for the more minority groups in society, so ensuring that we try and ensure that we have demographic representation across the board in all research wherever possible. And obviously if we're focusing on specific demographics, then that's more difficult, but wherever possible we should try and do that, so that we are being as representative as possible across our research.
Inclusivity is key, and finally, Dean, to you on that. So the one gap you would say.
Yeah, I completely echo both of your points. I think prevention and epidemiology of disease is, it's the cornerstone. If you don't understand that, then treatments don't come downstream from that. So I think we need a better understanding, perhaps, especially around mentioning these early age of onset cancers. We really don't understand why that is happening, and it's an absolute explosion. It's not just it's UK, it's across the world. It's India. It's sort of everywhere, really. And it's not genetic reasons. This isn't something that's there's a strong family history or something. This is affecting 30-year-old vegan marathon runners. I mean, how can you look at somebody like that who's got an advanced cancer and say,
even when you're looking at environmental issues, it's difficult.
Yeah, exactly. Yeah. It must be environmental stuff. There's some good research going on with a colleague, Gareth Jenkins in Swansea, the Mutagen Society, looking at nanotoxicity. I think that's a really strong area that research needs to focus on. And just secondly, absolutely looking at levelling up inequalities. We know for a fact that there are huge disparities in cancer outcomes, even within Wales. There's a 70% worse colorectal cancer survival in Asians compared with whites in Wales alone. And there's a multitude of reasons for that. They are addressable. We're looking at ways with, I saw Ashra Khanam at the back of the room, we're working on a project with her, looking at blood test acceptability for gynecological cancers. And some of the things we're reading from the responses is just would be a game changer. People so much more happy to have a blood test done in their local community centre than waiting for symptoms to come along, or being offered invasive cervical screening that they don't quite understand the value of it. We've got to do better to level things up and understand the challenges to why we are still seeing worsening disparities in the Western world. Thank you.
Lots of things to hopefully be optimistic about, but equally lots of things to be improved, and can make us slightly downhearted as well about where we are. This one's a similar question to the last one, so it might be quite brief. But if you've got your crystal balls and we're looking into the future, what would be the change that you'd like to see? And then over the next 10 years, we've been reflecting on the last 10 years, but what would that that crucial change be? If you could name one thing that you could say, right, this is what I want, this is what we need, that would make a greater difference to overall health care. Nathan, do you want to go first on this?
Thank you. I think it comes back to what I said before. As a health economist, I'd like to see health economics embedded into all research in health and social care. So I think if we could build up the toolkit and the understanding, and also to help our clinical researchers to understand the benefits of putting health economics into their work, I think would be fantastic. It would make it easier to evidence those, where the value is and how to assign the finite resources we have. So yeah, I mean it's quite a boring answer from a health economist, but that's what I would go for.
But having the data is also so important to
absolutely.
Right through. Thank you. Peter.
The one word I put down in response to this question was embedding. I sit on the implementation group for the embedding research in the NHS in Wales. And it's amazing the amount of work going on to get research into all professions and just increase its uptake, get more people to think about research, evaluation and innovation. So I think that the change that I think would be really welcome in the next 10 years is to get a much larger number of young researchers coming up from nursing, AHPs, midwifery, from primary care, and getting that mindset right throughout the NHS, because it's going to improve pathways, it's going to improve treatments. And a very quick example of that, which isn't Welsh, I'm afraid, but comes from the Royal Stoke in Stoke-on-Trent, where I was treated for my stroke. There's a stroke nurse has just got NIHR funding to spend, I think, a day or 2 days a week to research her idea that when stroke patients have a feeding tube, there's got to be a better way of checking it's in place and just monitoring it. And I won't go into details, but if her idea proves correct, then that's going to transform in a very quick and simple way the life of a bedbound stroke patient who might be tube fed for weeks or months. It's going to make their life a lot more pleasant. So tiny little things like that.
Honing in on those things that can make a huge difference.
Yeah, and they're coming right at the coal face in terms of someone that's day-to-day treating a patient on the ward.
Absolutely. Dean, what would be your one big change in your crystal ball?
I think making research as business as usual. Clinicians see patients every day. Patients really want to take part in research. They feel it's a way of giving something back to their clinicians to contribute their blood or their data or their understanding of their disease back to us. And we've got to make that easier, really. We've got to make routinely collected data more easily available. We've got to empower clinicians to facilitate their time to take part in research, because it's an absolutely wonderful part of the role, I think. It stops people getting burnt out. It's really exciting for young people to come up with a new innovative idea and to take it forward and see it through. It embodies the workforce for the future to be involved with that kind of thing. So I think that's absolutely crucial. I think it's happening in small steps, but I think we've got to accelerate it quicker, really. And also perhaps just to really make it easier to accelerate ideas through to translation and transformation. Evaluating innovations much more rapidly, doing the health economics right up front, getting the patient view right from the start. I mean, you can't write a grant application nowadays without a public involvement partner, which is absolutely the right thing to do. You've got to do researches for public benefit, but it's got to be with them on board. Otherwise, you're just coming up with ridiculous questions that don't mean anything to anyone, really.
So speeding it up and smoothing it out, ideally, over the next 10 years. And as you say, perhaps the media have got a part to play in embedding that in kind of everyday life as well, the research element for people to make it a bit more the norm in how they approach life. Really interesting. Thank you very much. We're going to see whether there's questions from the audience now as well, because there's so much covered there from so many different perspectives as well. So have we got our roving mics? I think we've got another mic up here. If you do need to come and grab the other mic, we've got that on stage. But do we have any questions? Yes, a gentleman here, about 4 rows back. Can we get a microphone to the gentleman just near the front here? Or I can... Have we got a microphone coming? We have got a microphone coming. Just be patient. It is on its way, I promise you. Just here in the front here. Just put your hand up. That'd be absolutely fabulous. Thank you. Thanks. Thanks, Toby.
Thanks. I was very struck by the length of the journey to get to practice. And at a conference on AI in the States recently, much time was devoted to a section on implementation science. And departments of implementation science seem to be cropping up in big institutions across the States with professors of implementation science and whole teams that take all those ideas and try to negotiate the hurdles and shorten the journey to practice. Is that something you think would help for us in Wales, or have we got the bases covered?
I think I might going to come and take a seat whilst you answer the audience questions, I think.
No, I think that's a great question, and it is an evolving area of practice. You have to sort of prove something works academically before you can get the sort of commercial funding to sort of take it forward and translate it into practice. And then you've got a mountain of regulatory issues to get through to make sure what you're offering to the public is safe and effective. But up until fairly recently, there's been no real roadmap for that. There's no cookbook. It's like sort of starting to bake a cake without really knowing what ingredients you need, and all of a sudden you realize you haven't got any raisins on the shelf, and you need to go off and find some of that and some of this. And so I think you're absolutely right. It's engaging researchers who've got bright ideas with teams who have been there and done this before, and know what hurdles and roadblocks you're going to face, and helping to break down and recognize those barriers early to speed them through. It is coming, I think. I think there are things like the MedTech mandate coming through from government to try and accelerate medicines and devices through the regulatory processes to get them in the hands earlier. But it's the lucky few that get selected for that. It's a real competitive process still. There's plenty of grassroots things that could benefit from that approach that, there's just not the scale at the minute to allow that to happen. I don't know if you want to add anything to that.
No, I think that's it's very true. I think we have things like university health boards and knowledge translation partnerships to try and bridge that gap between evidence and then practice. But I think potentially moving forwards, having dedicated centres for ensuring that happens in a smoother way is probably the way forwards to ensure that evidence is used in a timely manner and in a way which is responsive as well, I suppose.
That's a whole new academic discipline I've never heard of. I think that's a really important area because public expectations now are so high of AI and all these massive data banks that we have in health for a new cure to pop up. I think this is how it's going to be over the next 10 years. People will expect new cures or treatments to pop up like every 5 minutes. And AI is probably going to take us down that route, and getting them correctly implemented, if they are real and good, is going to be so important. But I think there's also a bit of an onus on the media to help in managing public expectations about exactly how much AI and all this health data can do.
Yeah, I think I'm picking up a lot of things I need to take back to my newsroom today, to things we might be able to focus on over the next 10 years, in fact. Any more hands up in the audience? Can we get to the gentleman there? Hand up. Thank you.
Yeah, I was going to ask, could we learn from like patient success stories as well? Because a lot of cases is like doom and gloom in a lot of cases with like with regard to research. So with regard to like mental health, we would like to like see more like success stories and what we've learned and how we are developing it much better. And I could see it in like the other areas, I can imagine as well. For example, like with the autism side of it, is a lot of people are not having training as well. So this is the other one I want to see as well, is like giving them more options of autism training and all that. But I'll leave it at that, otherwise I'll be here forever.
Who wants to pick up on that one, Nathan?
No, thank you. I think that's a really good point. I think that's a communication issue, and it relates to impact as well. So a lot of what we do now is we want to just do our research and then publish it and then move on to the next thing. But actually we need to start evidencing impact, and that's going to be a big part of the next research excellence framework cycle. And part of that, I think, is actually having case studies from patients who've benefited from particular interventions or treatments, or have taken part in a piece of research and had a positive experience from it. And I think that also that's where co-production is really important, because that can actually tell the story of the research from the participant's perspective, regardless of the fact that it might be anecdotal, but it's still interesting, and it still allows us to communicate what the benefits are at an individual level as well as a more general level from the research. So yeah, I think that's something we really could do more of. And yeah, the problem is a lot of the time is funding. We don't have a huge amount of funding for publications, so we need to start maybe building in grants as part of our grants, money for co-production, for publicising not just the research results, but the pathway to getting those results as well.
In terms of success stories that was alluded to, Peter, your stroke was 5 years ago. Have you, with this work that you've been doing with other people who have experienced strokes, have you had feedback from them? What sort of things have you seen in that arena since then, and since the work that you've been doing?
Just the amazing spirit and resilience of people that have had strokes and have had far worse outcomes than I did. And to come back to that gentleman's point, the storytelling on this whole agenda is so important, because there are so many good news stories out there, and even difficult, complicated pathways that don't go smoothly. We can commission Ivor to write some poetry about it, and that would raise everyone's spirits.
There we go. There's one for later. Dean, is there a good news story that you can share, maybe, to continue that positive trajectory from the colorectal cancer kind of arena?
Yeah, we've had some with our gynecological blood cancer testing, we've had a free text box at the end of the questionnaires, and we've had just some, incredibly emotional and, heartbreaking, but also really, really positive feedback from the public about, how they would see this as a massive leap forward in how we can detect things earlier. But I think we've also got to have a better way of communicating results back to the public. The number of research studies that make publication is a proportion or a percentage. The number of publications that get picked up by the media are, a fraction of the percentage, really. I think, we've got to have better ways of communicating results to sort of public fora and community settings. I remember one of my bestest ever time of going to speak to the public about results was when I presented some data really early on with Maggie's in Swansea, just when this sort of research into the blood test really looked like it was going to show positive results, and just sharing that with the local community who been through cancer treatment, having to have colonoscopies every few years, and just seeing that glimmer of hope that it could really just change the journey for them in the future. I'll just never forget that. And that's what sort of keeps you as a researcher at it and wanting to get it over the line.
Maybe we can change this panel into a podcast, and that's the way forward to spread the news about research. Maybe there's a future in that. Any more hands up on the floor? Because I don't want to have missed anybody. I missed some earlier, so my eyesight must be failing me. No, I don't think I've got any, which is good. Well, thank you very, very much, all of you, for your contributions this afternoon on the subject, what difference is research making to healthcare delivery and patient care? So many different examples, so many different areas which we've covered. So put your hands together for Nathan Bray, Dean Harris, and Peter Hooper, please.